I'm Jessica Quintero, Acting Director of Education for Heartland National TB Center. I will be covering the communication skills and interview question types. This section will focus on basic communication skills that can be applied to any healthcare worker-patient encounter. However, the main goal is to apply this to the contact interviewing process. After this session, you will be able to describe how to build rapport, list at least 6 effective communication skills, describe assertive, passive, and aggressive behavior, describe 4 different types of interview questions, and finally, list questioning pitfalls to avoid. Building rapport. Building rapport is the key to a successful case healthcare worker relationship. Rapport can be defined as a relation of trust between people, a feeling of sympathetic understanding, in accord, harmony, and having a mutual understanding. So basically, rapport is the quality of the relationship between people. Even more simply put, rapport is a friendly connection between people based on mutual liking, trust, and a sense that they understand and share each other's concerns. When there is rapport, it's easier to reach an understanding, to resolve differences, and to make decisions. Establishing rapport is the result of communicating effectively. So how do we build rapport? By the use of effective communication skills, finding a common ground, and displaying respect and empathy. In this section, we will focus on using effective communication skills to build rapport. Please note that exercises will be made available via Blackboard and will be discussed further during the live sessions. I will be discussing the following communication skills: active listening, using appropriate nonverbal communication, using appropriate voice and tone, communicating at the case's level of understanding, giving factual information, using reinforcement, and summarizing important points from the conversation. Keep in mind, everyone has their own communication style. These are just tips that can help ensure that the interview goes well. You should always be sincere and natural when using these tips. What is active listening? Active listening is the process of hearing what is said and paying attention to how it is said so the conversation can be adjusted to elicit the needed response. Active listening utilizes various verbal and nonverbal techniques. Paraphrasing and summarizing, reflection, and silence are all techniques used to show you are actively listening. We will discuss each of these more in depth in the next few slides. What is paraphrasing and summarizing? It is the rewording or rephrasing of the case's or contact's statement in order to verify information and show that you're engaged in the conversation. How do we do this? By using phrases such as, "What I'm hearing is," or "It sounds like you're saying," but don't repeat the patient's words for words exactly. Remember that the point is to verify what is being said and to show that you're actively listening. Avoid using the phrase, "I know what you mean," because if you've not been in this exact situation, if you've never been in TB contact, never been in TB case, then you don't know what they mean. Here's an example of paraphrasing. If the case says to you, "I'm feeling very tired these days and the meds are messing up my drug use. I don't know if it's all worth it." One way to paraphrase the quote is to say, "It sounds like you're considering not taking your medications anymore." Or, "What I hear you say is that you're tired and not sure if continuing with medications is worth it." Here's another example. If the case says to you, "I can't tell you the names of all my contacts. I just hang out at the pool hall. There's a guy we call Slim, another one JD." One way to paraphrase this quote is to say, "So you don't know the full names of many of your contacts." Or, "Let me make sure I understand you. You hang out with some guys from the pool hall, but only know them by nicknames." Reflection. What is reflection? It's putting words to a case or contact's emotional reactions. Acknowledging the case or contact's feelings shows empathy, and it helps to build rapport. Reflection also helps to check in rather than to assume you know what is meant. How do we do this? By reflecting back to the case or contact what you believe they have said to verify your understanding. Using phrases like, "It sounds like you're feeling," or "I understand you're having trouble with." So for example, if the case says to you, I'm feeling tired and this whole interview is making me nervous, you are asking me too many questions. One way to reflect the question is to say, I understand that this interviewing process may be overwhelming, or it seems like these questions are making you uneasy. Another example, if the case says to you, I don't want an HIV test, I don't want to know if I have AIDS, if there's nothing I can do about it, what's the point in knowing? One way to reflect the quote is to say, it sounds like the HIV testing process may be scary for you, or you seem quite passionate about the HIV testing process. How can silence be used to indicate you are actively listening? Silence allows the case an opportunity to answer questions. Silence is also an effective way to encourage a response to a question by allowing the person being interviewed an opportunity to answer the question. So some people are uncomfortable with silence. If the case is uncomfortable with silence and you're not saying anything, eventually they're going to fill the gap with something. What you have to be mindful of is that if you're also uncomfortable with silence, you have to kind of push through that and give the case an opportunity to continue the dialogue or start the dialogue or answer the question. Silence can also be an indication that there is a thought process occurring, so be patient. Give the person time to gather their thoughts, and remember, the interview is about them and their context. Nonverbal communication is an important aspect of building rapport. Both you and the case or contact communicate via body language. You should always display appropriate body language and be observant to the case or contact's nonverbal cues. Nonverbal communication can set the stage for the interview. Sometimes negative body language can be displayed without you even knowing that you're displaying it, and this can cause the person being interviewed to become reluctant to share anything with you. What are some nonverbal communications for the interviewer? Having appropriate eye contact. And by appropriate, I mean, is it both culturally appropriate and is it natural and non-dominating? Facial expressions. Do you look attentive? Do you look bored? Posture. Leaning forward indicates that you're interested in what is being said. Kind of being lackadaisical and leaning back and crossing your leg over your knee, that can show that you're not interested in what's happening. Gestures. Nodding your head also lets the case or contact know that you're following along with what is being said. Movement and mirroring. If the patient leans forward, then you should lean forward a little bit. If they're standing, you should be standing. If they're sitting, then you should be sitting. Eye contact, facial expression, posture, gestures, movement, and mirroring are all different ways of showing nonverbal communication. Interpreting the case's body language. If the case is expressing faltering eyes, again, lack of eye contact can indicate boredom or fatigue. But then again, keep in mind that this is only relevant if it is culturally appropriate to maintain eye contact. Intense eye contact, on the other hand, can convey fear, confrontation, or anger. Rocking represents fear or nervousness. A stiff posture indicates discomfort or nervousness. An elevated voice can mean anger or confrontation. Fidgeting, like rocking, can indicate nervousness, but also discomfort or disinterest. And possible drug use. Prolonged or frequent periods of silence can mean the case or contact is disinterested, losing focus, or maybe they're just tired. So it's important to pick up on these cues when the patient is silent. If they are being silent because they are thinking of a response, or are they being silent because they are disinterested? These are some nonverbal cues that the case may display during an interview. You should pay attention to cases' body language. It's important to keep in mind that this table here is a list of possible meanings, and it doesn't necessarily reflect what the person is actually feeling. So take the opportunity to check in and ask the patient, are you okay to continue? Are you feeling tired? Checking in with the patients, that's all part of communicating. Remember, culture often plays a part in body language, and it is also important to be mindful of your own body language. Is the patient responding to your body language? Using appropriate voice and tone. Use natural volume and tone. If your voice is too loud, the case may be intimidated, but at the same time, if your voice is too soft, your message may be inaudible or sound hesitant. Your tone can also affect your message. If, for example, let's say you say, nice hat, or nice hat. Exact same statement with two totally different meanings based on the tone used. Be mindful of your pace. Use a regular pace when speaking. If you speak too fast, you can indicate a sense of rushing the patient. But if you speak too slow, you can come off as sounding tentative. Maintaining an appropriate level, tone, and pace, it can be kind of tricky. You really have to know what your tendencies are so that you can adjust accordingly. Personally, I tend to talk fast and loud, and sometimes I'm very excitable. So I have to be mindful of that. I really have to take a minute to slow down, literally have to tell myself, okay, slow down now, because I know that for one, that's not acceptable in all circles, and it's certainly not acceptable in an interview setting. But that depends also on who I'm speaking to. For some people, I'm a bit much and I have to slow down. And I only use speaking fast as an example because that's something that I constantly have to work on. But this can work for other things. You know, do you talk too low? Do you mumble? Things like that. Again, it's being aware of your tendencies. So for me, if I'm interviewing someone that I notice they're speaking fast, then I give myself the green light to talk at my normal rate. And I just check in with them to make sure they're okay. I actually always check in prior to starting an interview. And I let them know, I tend to speak fast. I'm trying to work on slowing down. Please stop me if I'm speaking too fast. And then further conversation, I'll check back in. Please let me know if I'm speaking too fast. If you have a patient who's speaking slowly, then for me, I really have to dial it back. So I try to match my pace to their pace. This goes back to mirroring. I'm doing what they're doing because that's their comfort area. That's what they're comfortable with. And I want to make them comfortable. Communicate at the case or context level. Avoid technical terms and jargon. Limit the amount of information provided. What's need to know versus nice to know. Clearly explain necessary medical terms and concepts and repeat information. You know, as adults, we have to hear concepts multiple times before we finally absorb that concept and we make it our own. So if it's really important information, be sure that we're repeating it so that we have mutual understanding. Also, be mindful of your use of jargon. You know, we like to throw terms and acronyms around when we're talking shop, but the case and context are not familiar with these terms. At least at the onset of treatment, they're not. A few months into treatment, they start throwing around DOT and sputum too, but let them get there first. If you're going to refer to CI, you first have to explain contact investigation, and then explain that it's sometimes referred to as CI. Giving factual information. Be sure to correct misconceptions. Provide comprehensive TB information and avoid irrelevant information. Again, it's great that you have all this TB knowledge, but you need to ask yourself, does this information benefit the patient? This goes back to, is it nice to know or is it a need to know? Use reinforcements. Sincerely compliment or acknowledge the patient after hearing intentions to use or descriptions of healthful behaviors, such as, I appreciate your willingness to delve into this difficult issue. Be sure to smile, be sure to nod, and be sure to use affirmative words. Throughout the conversation, periodically summarize what is being said. Summarizing gives the case an opportunity to correct information that you may have misunderstood. It also lets them see that you are actually listening to what is being said. Give the case an opportunity to summarize the conversation back to you. For example, we've discussed a lot today. In your own words, review for me what we have discussed. Or, please tell me what you heard me say. This will help me provide you with additional information. I also use this checking in question to start the education process. Typically, patients are diagnosed outside of the TB clinic and have already been given some sort of TB education. I like to know what they've been told and what they understand about their disease, whether it be factual or not. This gives me an opportunity to either build on their knowledge or to correct any misconceptions they may have about TV. Avoid phrases such as, "Do you have any questions?" because the answer is usually going to be no. Rather, go back and say, "What questions can I answer for you?" So they'll respond no either because they don't know what questions to ask, or they're just ready to end this interview. They're tired, they don't understand the process. So we don't want to just ask them, "Do you have any questions?" Another question to avoid is, "Do you understand?" No one wants to come across as not understanding. So even if the answer is no, you're going to get a yes. Think about your own experience when you go to the doctor. Think about when you're in a setting that you're not that familiar with. Communication pitfalls. And there are a lot of them. Pitfalls to avoid. Avoid being distant or interrupting, giving false assurances, providing personal opinion and advice, and not seeming natural or sincere. So again, if you're going to do the interview, be present. Be present in the moment. Be present with the patient. Don't be distracted. Don't interrupt. If you ask the question, "Tell me how you spend your free time," and the patient starts to respond, "I play in a softball league with some friends," and then you cut them off and say, "Actually, softball doesn't count because that happens outdoors. Tell me about your indoor activities." That is going to break apart any rapport that you have started building with your patient. You may also miss the fact that the softball games are held behind an ice house where the patient hangs out afterwards for some drinks with teammates. Don't give false assurances. The most common one that I know of is telling a patient that they'll be released from isolation in 2 weeks and then they can go back to work, which is not necessarily true. Or telling the case, "Your family will be glad that you gave me their information," because that's also not necessarily true. Those kinds of false assurances would just destroy any rapport that you have with your patient. Avoid providing personal opinion and or advice. Again, whatever things the patient may be sharing with you, because sometimes they share a lot. They're not seeking your opinion or your advice. If the patient tells you, "My boyfriend will leave me if he finds out I have TB," you should not offer advice. Don't tell the patient, "If your boyfriend loves you, he's going to stick around. And if he doesn't, it's just not meant to be." That's not our role here. Finally, be natural and sincere. If your patient is covered in tattoos and you're not a tattoo person, don't say, "I like that tattoo on your arm," unless you genuinely and sincerely like that tattoo on their arm. Because you'll come across as being insincere, and the insincerity will come through to them as you not being trustworthy. Some additional communication pitfalls to avoid are overpowering your case by speaking loudly, standing above them, or using condescending statements. You also want to avoid asking several questions at once and being aggressive. The biggest thing about communication is being mindful of your own communication style, and again, adjusting your style to match the clients that we serve. Speaking loudly can come across as intimidating to someone who is a little bit more introverted or soft-spoken. Standing above them, again, we shouldn't be standing above anybody. If they're standing, we're standing. Condescending statements. Just be mindful of what you're saying and the way that it comes across, or the way that it can come across. Asking several questions at once. It's not just confusing, but it's overwhelming. So as the conversation progresses, you're certainly going to have additional questions. Make note of them and ask them at the appropriate time. So you ask a question, and within the response, you start to think of additional questions. Give the patient some time to finish what they're saying before you start peppering questions in. Because if you do that, you're not going to get thorough answers to the questions you're asking anyway. Being aggressive. I know that you really want to go in there and get all of your questions answered, and we have a lot going on sometimes. Some days are really busy, more so than others. If this is one of those days and you have one of three cases that was just given to you, all of which require interview, and the patient is not being cooperative, that doesn't give you the go-ahead to go in there and be aggressive with them. Don't go in there and say, I'm here under public health authority and you are required to answer all my questions. Assertive, passive, and aggressive behavior. During contact investigations, we are often faced with the challenge of trying to maintain rapport by respecting the case's wishes to privacy against what our main goal is as public health workers of identifying, testing, and treating contacts as necessary. So it can be difficult to live in both worlds. We kind of have a foot on each side of the fence. It often requires you to be assertive. Assertiveness is both a communication skill and a problem-solving skill. Assertiveness can be defined as maintaining one's rights without compromising the rights of others. Passive can be defined as relinquishing one's rights in defense of others, and aggressive can be defined as demanding one's rights at the expense of others. Here are some examples of different approaches. Passive. You're not supposed to smoke in here. I wish you would wait until after class. Assertive. Although you may smoke outside in the courtyard, smoking is not permitted in the building because it is a health risk to others. And aggressive. How can you be so disgusting and insensitive smoking in here? You're bothering people. As you can see in the first example, we're not asking them to stop smoking. We're saying, we really wish they wouldn't. In the last example, the aggressive example is just rude and we shouldn't be talking to our patients, cases, or contacts like that. The assertive statement lets them know that smoking is not allowed and why. Assertive behavior enables us to act in the best interest of the contacts, to stand up for them and exercise their health rights without denying the rights to the case. Assertive behavior is driven by empathy and logic. Acting assertively is more likely to produce functional results. Keep in mind, though, that culture can play a role in how people perceive behavior. So again, contacts have a right to be tested and treated, but cases also have a right to privacy. By being assertive with cases and others, we're not only asserting our rights, but also the rights of those not in the room, such as the contacts. To be effective in this role, you must believe in the contact investigation process and your role as the interviewer. Being an interviewer is not easy. We're coming into people's lives at a difficult time, meeting them for the first time and telling them, hey, aside from everything else you have going on medically, I also want to know who you've been around in the past 3 months. That's a tough sell. So if you come in and your approach or your discussions, your communications with them is either too passive or too aggressive, you're not going to get the information that you want. Remember that you have the responsibility and the obligation to elicit this information. The contact investigation is the responsibility of the health department. There are a variety of question types that will be discussed on the following slides, which includes closed and open-ended questions, probing questions, and checking questions. As the interviewer, you must know when to use the appropriate type of question to promote and encourage discussion with the case. What are closed-ended questions? A closed-ended question can be answered with a yes or a no. Closed-ended questions do not facilitate a conversation, but they can still be useful, so don't totally omit them from your interview. There are times when you need a specific yes or no. Answers such as, have you noticed anyone coughing? Some additional examples of closed-ended questions are, do you have TB symptoms? Or, have you ever been tested for TB? An alternate way of asking these questions are, what symptoms or problems are you having? And, when were you tested for TB in the past? Can you see that the alternate versions provide an opportunity for more discussion? What are open-ended questions? Open-ended questions require a descriptive answer and promote discussion. Once an open-ended question is asked, you should allow the case time to respond. So remember, you're asking them a question that they have to think and then respond. So be sure that you give them time. Here are a few examples of open-ended questions. What symptoms do you have? When did your symptoms begin? And who lives with you? You can see that these questions require the case to give more information than just yes or no. Probing questions. What are they? They're questions used to gain more information, and they can be either open or close-ended. Here are a few examples of a probing question or statement. Please describe who visited your home or lived with you in the past 3 months. And you mentioned that your aunt came to visit. Please tell me more about that. What are checking questions? Checking questions are specific and targeted questions to assess the case's understanding of the information that's been given to them. For example, why do you think we need to test your family members for TB? Or why is it important for you to take your medication every day? This is your opportunity to check in with the patient to ensure that there is mutual understanding of what has been discussed. And if there's not, then stop and clarify any concepts that have been misunderstood. So as the interviewer, how do we select which question to use? Begin with an open-ended question. If your question is not answered, move on to a probing question. But before you move into a new subject, be sure that you use a checking question. Close-ended questions are useful when you need a definitive answer. Keep in mind that this is all just a suggested format. Every situation is different and they may require a different approach. Again, it's just important that you are sincere. Some questioning pitfalls to avoid. You can see that many of the same communication pitfalls are also questioning pitfalls, like asking several questions at once, interrupting and not providing enough time for the case to answer your questions. Some additional pitfalls to avoid are asking leading questions and putting the case on the spot. A leading question is a question where you provide the answer that you're looking for. So for example, you would say, "You don't have any kids at home, right?" To which the answer would be, "Right." Or how much alcohol would you say you consume in a day? 2, 4, maybe 6 cans? To which the answer would be 2. And we definitely want to avoid putting the case on the spot. Don't ask, "Don't you want to keep your friends from getting TB?" You don't know what kind of baggage the person's coming in with or what else is going on in their lives. So asking a question like that really puts the patient on the spot. And that will affect the kind of communication that you guys have further into the interview. This concludes the communication skills and interview question types portion of this course. Thank you so much for your attention.